Hello, this is Dr. Bill White again, and I want to go over a video that I've already done, one on this, but I didn't cover some points that I wanted to discuss with you on this, and I appreciate very much these gentlemen in Sweden, and this is one of them, and then there's a Dr. Eriksson here, and they did a real contribution to joint work to show us how it works, and I appreciate them very much. But I'm going to go through some of the things that they covered with us and show you what I wanted to tell you about these things. So I'm going to stop this. This is just a picture of a jaw joint, and I think everybody pretty well knows it. This is the condyle right here, and the jaw is out to our right, and it's a open. If this one's opening, then this will move out here, and this is the disc that is biconcave. It has it's like a big donut or something with a lot of inside tissue on it, and it'll have a ridge out on this side and a ridge back here, and this mechanically kind of keeps the head of the condyle on this disc, and there's a separation of the space. There's a super or above or a disc space up here, and then this is the lower disc space, and the synovial fluid is secreted into this tissue here and into this up here, and that synovial fluid is fantastic. It is a kind of a like blood plasma, except it's got food particles in it, and how it manages to do its job is just I do not understand fully. Now this area back in here is what we call the retrodiscal tissue, and it's highly vascular. It has to come in and it purifies this synovial fluid, carries a waste product from this back into here, and the bloodstream carries it, and I guess the kidneys take care of it from there. But this has nerve endings, a lot of them, and a lot of blood vessels, highly vascular area back here. So you never want to shove this condyle, this area right here, back into that. So if somebody gets hit in the jaw and it shoves their jaw way back here, they don't have a mouthpiece, and really bruises this vascular area, and it gets sore, then they'll have a jaw joint problem. And as they close, it presses on that swollen area, and here people might take a drug that would reduce the swelling and help you a little bit, but all the things we do to this is just a kind of a helping. But we've got to bring the jaw forward to stop the pain, to get rid of most of the pain. If you let the jaw close like it wants to, it won't impose on this tissue right here. So this is a still picture, but I'm going to go to a moving picture of it in just a minute, and you can see more about it. And you can see this synovial fluid is a fantastic material. It's the slickest thing we know of. We can't make anything as slick as that. And this apparently does not wear out. I'll be 92 at my next birthday, and my jaw joints work smooth and easy, and I got hit real hard once, and this one, if I abuse it at all, it'll start hurting some, but I just take care of it and it quits, and normally I don't have any trouble with it. But the jaw joint is, both of them just move good, and I'm nearly 92. So this tissue has to heal up, and it doesn't grow anything like that, but it doesn't wear out. It heals itself, and the waste products are carried out through the synovial fluid back into this retrodiscal tissue that's highly vascular, and it's purified, I assume, in the kidneys and sent back to feed this. Now, this tissue right here that takes the pressure, if this person were to bite down here, this condyle will push up against that. Now I'm going to try to go to this moving area, and you can see for yourself. And these gentlemen there in Sweden did a real contribution when they did that. And I have such a much better understanding of the joint. So we'll just turn this on for a minute, and I'm going to move over to an area where they're talking about it, and they did something. Now here we'll stop. Now, this is a live person, but this is a cadaver that must be quite fresh for the tissue to be this soft and pliable. And they cut down this, and I appreciate this person donating their body for this, to understand this. Now here is the back part of that donut, and this is the mound part. This part right here is the center part, and then there'll be a thick part out on the right side of where we're looking at it here. Now, and that double concave thing, it's big on each side and thin in the middle. Now the part in the middle is where the pressure is, and there's so much pressure when you bite, the muscles are right in this area, and you bite your front teeth together, and if you put any pressure, like say 10 pounds out here, you may have 20 or 25 or 30 pounds of pressure in the joint area on both sides. And this tissue is so tough and is pressed so hard. There are no nerve endings in this tissue and no blood vessels. And it takes too much pressure to have them. So that tissue has to be fed by this synovial fluid that comes from this tissue back here. And you have a lower joint space and an upper joint space, and the two areas, the upper and the lower, are not connected. The synovial fluid up here is in one part of the capsule, and the synovial fluid down here is in the lower part of it. And it all goes back into this retrodiscal tissue and is purified, and fresh synovial fluid goes in there, and the joint is fed that way and repaired and everything, because I could not be 92 and have tissue that had been in there all my life. And it's just as smooth and operates easy, and it has to have been repaired and taken care of all my life. And I've chewed and played football, gotten hit in the jaw, and I'd have a mouthpiece. I used to do some boxing and get hit in the jaw, and this is not, my jaws are not something that had been taken care of and babied at all, and it's still working good. So this is tough material, but it had to have something to feed it and take care of it and supply the energy it takes for those cells to grow and stay healthy under all this pressure. Now let's watch this a little. I could touch this little deal and move it just a little bit, and you see it's closing up. Now the jaw is out to the right of the picture now, and this is the condyle, and this is the fossa, goes up here. And nearly all the illustrations you see of this fossil, it'll just round it off back here as if the condyle went all the way up here. It doesn't go up there. This large portion of the disc is squeezed up into this area, and the condyle goes back and pushes this. But as long as the blood vessels and this retrodiscal tissue has enough room there to where it's not squeezed and damage the blood vessels, it works fine. But if you do anything, and I tell you, people that say, well, I'm not going to mess with the TMJ, I'm not going to do that, I'm going to do my orthodontics and I don't want to fool with it. Well, this is foolish idea. You cannot work on the teeth without having some effect on it sometime. And just putting a thick crown on an upper central. One time I had a patient and the tooth was bad, so I sent him in and they put a crown. The guy didn't want to grind the back off of the tooth, so he made a gold back to the crown and made it thicker. And so when the patient bit down, the lower teeth, the bite was closed and the lower teeth went up and hit that crown, and that caused the tooth to get sore, or even just the forcing, closing the teeth, forced the jaw back, and that forced this condyle right here back into that retrodiscal tissue. And I hadn't sent the patient in, they didn't have that crown any time till they started having jaw joint problems. Now you could bathe it, you could massage it, you could put ice and all this, you could take an anti-inflammatory medication, might help it, but if you did not get rid of the cause, then it wouldn't be any good, because it's going to start hurting again. And so that's what you need to do. So now if you go in and have your wisdom teeth removed, so they open your mouth real wide. Well, this condyle is pulled way up over here, and that pulls this ligament so tight, and it's up against the retrodiscal tissue, and it pulls it so tight, and they sit there holding it while they take out a wisdom tooth or do something. Actually, it doesn't matter. In other words, they can be doing a tedious crown or several crowns and hold your mouth open for a long period of time. Then it's going to strain this area, and it'll get to hurting, and it'll hurt the jaw joint. Now, this type of pain, normally with a few days, it'll go away. But you can take some anti-inflammatory medicine, and it'll calm it down where you can get the condyle to close all the way. But when it swells up, it pushes this tissue into the position the condyle is going to take when you chew, and it hurts. So those people can't chew good for a day. They might have to eat out here on their front teeth, you see, to do that. So let's watch this thing move again, and I'm just going to touch it for a little bit, and you'll see it go back. I'm going to stop it again, and it's fixing to close up. And you see this thick portion of this disc, and here's the thick portion of the front part of the disc out here, and this is going to squeeze up into that space right there. And I just watch it go up in there. And I'll stop it now. See how it fits up in this area. Now this is the upper joint space is up in this area, and this is the lower joint space. Now this upper part of the ligament stretches out as you open, and the lower part wads up as it opens. You watch it. It'll wad up down here, because this part will be back down here on the condyle when they open, and this part up here, if you open real wide and you yawn or pull it, it'll hurt this, and that can cause you to have some pain with the joint. So let's watch it a little bit further. Now watch it close together, and I'm going to stop it there. Now apparently if this person wasn't having any TMJ pain, this is the retrodiscal tissue all up here, and this is where the synovial fluid goes in to supply this upper part of the disc, and it comes in on the bottom part and supplies the lower, and maybe they come together back here where this pressure is. Now this is the jaw joint, and you can see as it opens and closes. Now let me go a little bit further, and you can see the thick area back here, and the thick area in the front is out here, and here's the upper joint space, and here's the lower joint space here, and there's a separation between the two. And as you open, you stretch this one, and it wads this one up. As you close, this one wads up, and this one stretches out as you close this up. So I want to go there, and you watch that happen right here. Now as you open, you see this one wadding. Now when I close, it stopped. This goes down and comes up. And now right in here somewhere, we're going to change patients. Okay, there it is. Now this is a patient that has apparently had some difficulty in here, and maybe went for a time without this disc being fed, and this is actually an opening in the disc. And you've got the thick portion out here and the thick portion back in the back, and let's go through several rotations with that, and we'll try to show that to you. Now it's going down, and I'm just going to go through the movements of it and just watch it. They move pretty slow in this case, and this disc has got a hole in it. You see the thick portion here, and so this big donut is worn out in between here. Now this person may have damaged that disc bad, and it's worn out, and so now when they open and close, you can hear a kind of a grating sound. It's kind of something like you're moving something past and there's nothing in between. Maybe you've got synovial fluid is not properly treated and all this. Now, by the way, this jaw is opening to the left, the other one is opening to the right. And then just a second, another rotation or not, they're going to pull this condyle down, and you can see the disc itself from the top. And that's what I wanted to show on this. Now you see, when they bite down, the pressure goes bone to bone right here. This is a cortical bone around the condyle, cortical bone on the fossa. And this fossa has this lump up here, this stuff, retrodiscal tissue goes up in here, the part of the disc goes up in here, in this area. And this is your retrodiscal tissue back here. Now this particular one, and in just a little bit we can see them move this down. Let me go ahead and speed this up if I could. Now you see, if they open the mouth real wide, then the condyle has to go way on over here, and it stretches the heck out of this ligament here, but it wads this one up as it does that. Now I hope they get on back with that thing. It's kind of slow, and so it'll take us a few minutes here to get over it. Now they're going to take this they'll move this jaw down and pull the condyle away from it, and you can see where this hole is in the disc. And there's a lot of people have that, but they don't click and they don't make any noise except they scrape, and you hear it kind of like that. Now that is not a painful procedure, but it does happen. This is stopped. Let me speed it up, and they'll come down here, I think, and pick that up again. It's kind of hard for me to regulate this to show it to you like I would really like to. You have to watch this and think about that. This happens with everybody that comes into you. Usually with a jaw joint pain, they're going to have trouble with this condyle pressing on this area too much, and where the blood vessels can't survive and do properly and properly treat the disc in here. And if it does, then the disc deteriorates and breaks down. So I'm going to, hopefully they'll open this thing at this point. Let's see, maybe they will. We're still going. All right, now here they go. All right, they're lowering the jaw. The gentlemen that were taking this, now here is the disc. You can see this ridge around the disc. It's like a great big donut sitting up here on top of the condyle, and this part of it is worn out right there. Now I'm going to stop the video at this point and cover this other in another video. So I'm going to move over here and just stop it.